Welcome to this guide on acing your VIVA presentation. Today, we delve into a complex and compelling clinical scenario. We will explore the case of Tom, a 29-year-old man whose life has been quietly unraveling. Imagine this. Late one evening, a concerned neighbor brings a young man to the emergency department. This young man is Tom. He was found wandering the streets, lost in a world of his own, talking to unseen figures. His neighbor, the only person who checks in on him, has noticed a troubling change over the past few months. Tom has become increasingly withdrawn, a shadow of his former self, often caught muttering alone in his small apartment. This single act of kindness by his neighbor marks the beginning of our clinical journey. Tom's presentation is a puzzle with many pieces. He reports experiences that are deeply distressing and very real to him. He hears voices, a constant commentary on his every action, often laced with insults and criticism. Tom believes these voices emanate from his television, a relentless broadcast that continues even when the device is unplugged and silent. This is not the only torment he endures. He is unshakably convinced that a secret organization is watching him. He believes they have planted hidden cameras throughout his apartment, monitoring his every move with hostile intent. This profound sense of persecution has left him in a state of constant fear and suspicion, unable to trust the world around him. Beyond these frightening experiences, Tom's internal world seems to have faded to gray. His emotional expression is severely limited. He speaks in a flat, monotonous voice, showing little reaction to the people or events around him. This is what we call a blunted effect. He also suffers from a profound lack of motivation, a condition known as avolition. Simple daily tasks that most of us take for granted, such as bathing, cleaning his living space, searching for employment, have become insurmountable obstacles. This inertia has taken a significant toll on his life, contributing to his unemployment and poor living conditions. His personal hygiene is neglected, and his appearance is unkempt, further signs of his struggle. The things that once brought Tom joy have lost their appeal. This symptom, known as anhedonia, has stolen his ability to experience pleasure. He used to enjoy playing the guitar, losing himself in a good book, but these activities now lie abandoned, gathering dust. His thought processes have also become fractured. Tom's speech is often difficult to follow, jumping from one unrelated idea to another in a tangential and sometimes incoherent stream. This disorganization makes it hard for him to maintain a conversation or focus on simple tasks. He is easily distracted, his mind seemingly pulled in multiple directions at once, making it impossible to concentrate. This collection of symptoms paints a picture of a mind in deep distress. The purpose of this essay is to provide a clear and structured framework for understanding and managing a case like Tom's. We will walk through this scenario step by step, just as you would in a real-life clinical setting or a high-stakes VIVA examination. Our goal is to equip you with the knowledge and confidence to articulate your clinical reasoning effectively. We will cover everything from the initial assessment to long-term discharge planning. This comprehensive guide is designed to help you demonstrate a deep understanding of the science that underpins safe and effective clinical practice. We will show you how to evaluate assessment data and make sound decisions in response to a patient's altered mental state. To achieve this, we will employ a specific and powerful communication tool, the SPAR framework. SPAR framework SPAR, which stands for Situation Background Assessment Recommendation. This method is widely recognized in healthcare for its ability to ensure clarity and reduce errors. By structuring our analysis of Tom's case around the SPAR format, we will create a clear and coherent narrative. This approach will not only help you organize your thoughts during a VIVA, but also enhance your day-to-day clinical communication skills. It will serve as the backbone of our entire discussion, guiding us from one act to the next. Our journey will be broken down into several distinct acts, each focusing on a critical aspect of Tom's care. We will begin with a detailed SPAR-led assessment, exploring his acute presentation and relevant background information. Next, we will dive into the pathophysiology of psychosis, explaining the underlying neurobiology in simple terms and connecting it directly to Tom's symptoms. This will lead us to a discussion of differential diagnoses and the formulation of a likely diagnosis. From there, we will move on to pharmacology, examining antipsychotic medications, their mechanisms, and how to manage side effects and acute agitation safely. Finally, we will construct a comprehensive plan of care. Immediate management strategies. The role of psychosocial interventions. The critical importance of effective discharge planning. We will also touch upon the enhanced interpersonal skills needed to communicate with a patient who, like Tom, may not recognize that they are ill. Our learning goals are fourfold: to deepen your understanding of the underlying science, to sharpen your assessment and decision-making skills, to master the SPAR communication tool, and to apply pharmacological knowledge critically. By the end of this VIVA, you will have a robust template for tackling a complex psychiatric case with confidence and competence. Table of Contents. Part 2. Act 1. SPAR Assessment. About 5 sections. The SPAR Framework. A tool for clarity. Situation. The immediate crisis. Background. Piecing together the puzzle. Assessment. A comprehensive clinical picture. Recommendation. The immediate path forward. In any clinical encounter, especially one as complex and urgent as Tom's, clear communication is paramount. Misunderstandings or omitted details can have serious consequences for patient safety and care. This is where the SPAR framework becomes an indispensable tool. It provides a standardized structure for relaying critical information between healthcare professionals, ensuring that nothing gets lost in translation. SPAR stands for Situation, Background, Assessment, Recommendation. It is a simple yet powerful method that promotes concise, factual, and action-oriented communication. By systematically addressing each of these 4 components, we can build a comprehensive and easily digestible summary of a patient's condition essential for effective teamwork and decision-making in a high-pressure environment like an emergency department. The beauty of the SPAR framework lies in its logical flow. It starts with the immediate problem. Situation. Provides the necessary context. Background. Presents the clinical findings and your interpretation. Assessment. And finally proposes a clear course of action. Recommendation. This structure mirrors the natural process of clinical reasoning. It forces us to organize our thoughts, prioritize information, and move from observation to action in a disciplined manner. For a VIVA examination, using the SPAR framework demonstrates not only your knowledge of the case but also your proficiency in professional communication standards. It shows the examiners that you can think and act like a competent clinician, capable of leading a clear and effective handover. Throughout this act, we will apply the SPAR framework to Tom's case in detail. We will break down his presentation into these 4 distinct segments, creating a thorough and structured analysis. This exercise is not just for the purpose of the VIVA. It is a practical skill that will serve you well throughout your clinical career. It is particularly useful in mental health, where patient histories can be long and complex and presentations can be nuanced. Mastering this tool will allow you to convey the essence of a patient's situation quickly and accurately, whether you are speaking to a colleague, to a consultant, or another member of the multidisciplinary team. It ensures everyone is on the same page, working towards the same goal, providing the best possible care for the patient. As we proceed, we will populate each section of the SPAR with the specific details from Tom's story. For the situation, we will describe his acute arrival at the emergency department. For background, we will gather the historical and social factors. The assessment will detail our findings. Finally, the recommendation will outline the immediate steps required. This systematic approach will transform the chaotic details of Tom's presentation into an organized, actionable clinical summary, laying the groundwork for all subsequent decisions regarding his care. The first step in our SPAR assessment is to clearly define the situation. This component answers the question, what is happening right now? It is a concise statement that grabs the listener's attention. It immediately establishes the reason for the clinical encounter. In Tom's case, the situation is acute and concerning. Our handover would begin like this. I am calling about Tom, a 29-year-old male. He was brought to the emergency department tonight by his neighbor. The primary concern is his acute, psychotic, and disorganized behavior. He was found wandering in the streets, appearing disoriented. He was actively talking to himself. His neighbor reports that his condition has been deteriorating significantly. He is now presenting as agitated and fearful within the department. This opening statement frames the urgency of the problem. It identifies the patient. It identifies the reason for his presentation. It identifies the immediate safety concerns. The mention of acute psychotic and disorganized behavior signals the nature of the crisis. By saying he was found wandering, we highlight a risk to his personal safety. Being brought in by a neighbor rather than seeking help himself suggests lack of insight. The situation is not just psychiatric, it is a social and safety crisis requiring immediate intervention. We must also describe his current state in the emergency department. He is not calm. He is agitated and frequently looking around suspiciously. This observation adds another layer to the risk profile. His agitation could escalate, risking harm to himself or others in a busy environment. His fearfulness suggests active distressing symptoms like hallucinations or paranoid delusions. This is not a historical report, but a live, ongoing event. Therefore, the situation is an acutely unwell individual in profound distress, unable to care for himself and exhibiting unpredictable behavior. In summary, the situation section provides a sharp, focused snapshot of the immediate problem. It is the headline of the clinical story. For Tom, the headline reads, "Acutely psychotic young man brought to the emergency department in a state of distress and agitation, posing an immediate risk to his own safety." This concise summary lets any clinician understand the gravity within seconds. It sets the stage for the rest of the SPAR, prompting the listener to ask, "What led to this? What have you found?" This is the essential first step in mobilizing an effective and timely response to Tom's needs. Having established the immediate situation, we now move to the background component of the SPAR. This section provides the essential context needed to understand the current crisis. It answers the question, what are the relevant circumstances leading up to this event? For Tom, his background paints a picture of a gradual decline. Tom is a 29-year-old male who lives alone and has been unemployed for the past year. His neighbor reports progressive social withdrawal and functional decline over the last few months. He was previously employed as a cashier but was terminated due to erratic behavior and poor performance. No known past psychiatric history, no family history of mental illness, no significant medical history, no reported history of substance abuse. The timeline, a decline over the past few months, is highly significant. This suggests a primary psychotic disorder, for example, schizophrenia, rather than a brief, transient episode. Job loss due to erratic behavior is a major red flag. Symptoms have caused significant functional impairment for at least a year. This crisis is the culmination of prolonged deteriorating mental health. Lack of previous psychiatric history suggests a first episode of psychosis, important for diagnosis and treatment planning. Tom lives a very isolated life, minimal social contacts, avoiding family, avoiding neighbors, only regular interaction, neighbor who brought him in. Social isolation is both a symptom and a risk factor. No support network meant no early intervention. Poor hygiene and unkempt appearance on presentation, and inability to perform basic activities of daily living. These details highlight severe negative symptoms such as avolition and self-neglect. Absence of other contributing factors is as important as symptoms. These reported absences must be formally excluded clinically, but they help narrow diagnostic focus. Makes a primary psychiatric disorder more likely than psychosis secondary to a medical condition or substance use. Gradual onset, severe functional decline, social isolation, lack of other explanatory factors. Together, these point toward a developing schizophreniform illness or schizophrenia. This context is vital for interpreting the findings of our clinical assessment.
Narrator VO. With the situation and background established, we proceed to the assessment portion of the SPAR, presenting our clinical findings and analysis. Junior Doctor presents the assessment section to the team.
Narrator VO. It answers, what do I think the problem is?
Narrator VO. Start systematic and thorough. Begin with a mental state examination. For Tom, our assessment would be, Psychiatrist, we'll begin the mental state examination now.
Narrator VO. On exam, Tom appears unkempt, poor hygiene, he is agitated. Narrator VO. He is anxious and visibly fearful, guarded and suspicious demeanor.
Narrator VO. Affect flat, speech monotone. Tom speaks in a monotone, minimal content, unintelligible patient speech. Narrator VO. Thought process, disorganized, tangentiality and loose associations. Patient makes tangential comments, speech jumps topics. Narrator VO. Thought content, persecutory delusions, believes a secret organization is watching him. Tom whispering, they're watching me. The organization.
Narrator VO. Auditory hallucinations, commentary and insulting voices. distorted whisper audio representing auditory hallucinations. Narrator, VO. This captures the core psychopathology. Narrator, VO. MSE domains, appearance, behavior, affect, speech, thought process, thought content. Narrator, VO. Noted, positive symptoms, delusions, hallucinations, disorganized thoughts. Narrator, VO. Noted, negative symptoms, flat affect. Narrator, VO. Noted, disorganization, agitation, disorganized speech.
Narrator, VO. Assess orientation and insight. Clinician. What is your name? Where are we?
Narrator, VO. Tom is oriented to person, place, time. He has no insight, attributes experiences to external persecution. Tom. My name is Tom. I'm at the hospital, but they're watching me.
Narrator, VO. Lack of insight, anosognosia, is common in psychosis. Narrator, VO. Beyond MSE, include risk assessment and physical health checks. Risk assessment is a priority. Narrator, VO. Immediate risk, self-neglect due to poor hygiene and living conditions. Potential risk, harm to self or others from paranoid delusions and agitation. No expressed suicidal or homicidal ideation currently. High risk of accidental harm, wandering, disorganized behavior. Narrator, VO. Be specific about risk types and supporting evidence. Narrator, VO. Take vitals to rule out medical causes. Vitals documented as stable but necessary to exclude delirium or emergencies. Narrator, VO. Formulate differential diagnoses.
Narrator, VO. Primary impression, first episode psychosis. Schizophrenia spectrum. Psychiatrist, primary impression, first episode psychosis.
Narrator, VO. Leading diagnosis, schizophrenia, positive plus negative symptoms and 6 months decline. Consider schizophreniform disorder. Consider brief psychotic disorder. Narrator, VO. Rule out substance-induced psychosis. Rule out psychosis secondary to medical conditions. Encephalopathy, autoimmune disorder. Use labs and physical exam to exclude organic causes. Narrator, VO. This structured assessment underpins our recommendations. The final and most crucial part of our SPAR is the recommendation. This section is action-oriented. What do I need you to do? Based on our assessment of Tom's acute and severe condition, recommendations must prioritize safety and initiating treatment. My primary recommendation: immediate hospital admission. Immediate admission to an acute inpatient psychiatric unit for safety, assessment, and starting treatment. He is unlikely to agree to voluntary admission due to agitation and lack of insight. Initiate assessment for involuntary treatment urgently. The inpatient setting provides 24/7 monitoring. It prevents wandering and neglect. It allows a controlled setting to begin medication and observe effects and side effects. Considering involuntary treatment acknowledges anosognosia, his lack of insight. This balances clinical necessity and the legal framework, not a decision taken lightly, essential for safety and well-being. Immediate actions in the ED while awaiting transfer, one-to-one nursing observation for agitation and paranoia, verbal de-escalation techniques to manage anxiety and fear, offer oral antipsychotic medication, olanzapine, risperidone. If oral meds are refused and agitation escalates, be prepared for intramuscular medication per local rapid tranquilization protocol. Draw a full panel of blood work, complete blood count, electrolytes, liver function tests, urine drug screen. These actionable steps create a clear immediate management plan, behavioral, pharmacological, and diagnostic, a holistic approach integrating safety, diagnostics, and therapeutics from the start. To understand Tom's experience, we must look inside the brain. Psychosis is not a character flaw or a moral failing. It is a condition rooted in the complex biology of the brain. Our brain has a critical job to interpret the world around us. It takes in information from our senses, sight, sound, touch, and builds a coherent picture of reality. This process is called reality testing. In psychosis, this fundamental ability is disrupted. The brain begins to generate its own reality, creating perceptions without external stimuli, like hearing voices, or forming beliefs not based in fact, like Tom's conviction that he is being watched. This creates a profound and frightening disconnect from the shared reality of others. The brain is an intricate network of billions of nerve cells, or neurons. These neurons communicate using chemical messengers called neurotransmitters. This chemical conversation shapes everything we think, feel, and do. In schizophrenia, the balance of these neurotransmitters can be disrupted, leading to faulty signaling between brain regions. Imagine a telephone network with crossed wires. Messages get distorted or created out of static. That helps explain hallucinations and delusions. Several key brain regions are implicated in psychosis. The prefrontal cortex, our executive control center. It governs decision-making, social behavior, organizing our thoughts. In schizophrenia, this area often shows reduced activity, which can explain disorganized speech and avolition. The temporal lobes, especially auditory areas. Overactivity here links to auditory hallucinations, like the voices Tom hears. The limbic system, governing emotion and memory. Its involvement contributes to emotional dysregulation and paranoid fears. Understanding this biological basis is crucial. First, it helps destigmatize the illness. Tom's condition is a medical one, like diabetes or heart disease. It is an illness of a specific organ, the brain. Second, it guides our treatment approach. Antipsychotic medications target neurotransmitter systems to help restore a more normal chemical balance. Exploring pathophysiology builds a scientific foundation for compassionate care. It shifts our view from confusing behavior to symptoms with a biological cause. For many decades, the leading theory to explain the symptoms of psychosis has been the dopamine hypothesis. Dopamine is a crucial neurotransmitter. Motivation, reward, pleasure, motor control. The original simple hypothesis, psychosis from excess dopamine. Two key observations. First, amphetamines can induce psychosis. Second, early antipsychotics block D2 receptors, suggesting a link between dopamine and psychosis. The theory became more refined. The modern view, imbalance, not uniform excess. Excess, dopamine in subcortical pathways, especially mesolimbic. Mesolimbic, midbrain to limbic, processes salience, overactivity, positive symptoms, hallucinations, delusions. Brain assigns importance to random or internal stimuli. In contrast, dopamine deficit in other regions. Mesocortical pathway, midbrain to prefrontal cortex, important for executive function, cognition, emotional expression. Dopamine lack here and negative and cognitive symptoms. Tom's flat affect, his lack of motivation, his social withdrawal, his difficulties with concentration, and disorganized thought. It is this duality, an excess of dopamine in one area and a deficit in another, that makes schizophrenia such a complex and challenging illness to treat effectively. This updated understanding has profound implications for treatment. Traditional antipsychotics block D2 and control positive symptoms, but they don't fix prefrontal dopamine deficit and can worsen negatives and cognition. Newer atypicals have more complex mechanisms. They aim to reduce mesolimbic dopamine and increase mesocortical dopamine. Understanding the dopamine hypothesis is essential for making informed pharmacological choices for patients like Tom. While the dopamine hypothesis remains central, it is not the whole story. Researchers now believe other neurotransmitter systems are critically involved. One of the most important is glutamate. Glutamate is the brain's primary excitatory neurotransmitter, the main on switch for neurons. The glutamate hypothesis, dysfunction in the glutamate system, especially the NMDA receptor. Evidence, drugs like phencyclidine, PCP, block NMDA receptors and can produce positive symptoms, negative symptoms, cognitive symptoms in healthy people. This suggests glutamate problems may drive downstream dopamine imbalance. Underactivity of NMDA receptors, perhaps on inhibitory neurons, triggers a cascade. It disrupts the braking function in brain circuits, causing overexcitation. Chaotic signaling can cause secondary excess dopamine in the mesolimbic pathway, producing positive symptoms. Glutamate dysfunction may cause underactivity of the prefrontal cortex, contributing to negative symptoms and cognitive symptoms. This integrates dopamine and glutamate into a broader model. Another key player is serotonin. Serotonin regulates mood and it also influences the dopamine system. Atypical antipsychotics act on serotonin receptors, especially the 5-HT2A receptor. Blocking 5-HT2A helps reduce positive symptoms and may improve negative symptoms. This can increase dopamine in the prefrontal cortex, counteracting cognitive and negative symptom deficits while still controlling dopamine excess elsewhere. Schizophrenia is likely a circuitopathy, a disease of brain circuits. Balance between prefrontal cortex, limbic system, and basal ganglia is disrupted. Thalamus, the brain's sensory relay and cortex communication is faulty. This leads to poor sensory filtering, which may explain why people like Tom are easily distracted and feel overwhelmed, and may contribute to the formation of hallucinations and delusions. Section 4. Decoding the symptoms. From hallucinations to avolition. By applying our understanding of pathophysiology, we can begin to connect the underlying brain changes to Tom's specific symptoms. Let's start with his auditory hallucinations, the voices that comment on his actions and insult him. These are thought to arise from overactivity in the brain's auditory processing areas, temporal lobe, Wernicke's area. In a healthy brain, these areas activate when we hear external sounds. In psychosis, they activate spontaneously. One theory: misattribution of inner speech. We all have an internal monologue, normally tagged as self-generated. In schizophrenia, that tagging can fail, causing Tom to perceive his own thoughts as external voices. Next, Tom's delusions of persecution, belief a secret organization is watching and wants to harm him. This links to the dopamine hypothesis and aberrant salience. Excess dopamine in the mesolimbic pathway can make neutral events feel important. A passing car, a flicker on a screen, a stranger's glance might be read as evidence of conspiracy. The prefrontal cortex should evaluate and dismiss these beliefs, but it's underactive and can't perform the reality check. The result: a fixed, false belief system, impervious to reason and terrifying to the person experiencing it. Tom's negative symptoms: flat affect, avolition, anhedonia. Wadiat sodium diri, when he andadan en sodiat dodi and sodiat duarban and sedodiri. Equally debilitating, they're linked to dopamine deficit in the mesocortical pathway to the prefrontal cortex. Dorsolateral prefrontal cortex, key for goal-directed behavior and motivation. Reduce dopamine here. Apathy and avolition, making it hard for Tom to bathe, clean, or look for work. Ventromedial prefrontal cortex, emotion and reward processing, dysfunction there. Flat affect, limited emotional expression, and anhedonia, e.g., no pleasure playing guitar. Finally, disorganized speech and difficulty concentrating reflect core cognitive deficits in schizophrenia. These link back to prefrontal cortex dysfunction and its network connections. Prefrontal cortex supports working memory and executive function, holding thoughts, staying on topic, filtering distractions. When impaired, thoughts jumble and speech grows tangential and incoherent, as with Tom. His difficulty concentrating on simple tasks is a direct sign of executive dysfunction. Each of Tom's symptoms can be mapped onto current neurobiology of psychosis. Section 5. Formulating a diagnosis, from differentials to a working conclusion. With a thorough assessment and understanding of the underlying pathophysiology, our final task is to formulate a diagnosis. This is not just applying a label, it is a systematic process of hypothesis testing. We must consider differential diagnoses and use evidence to find the best fit. For Tom, our primary working diagnosis is schizophrenia. DSM-5 requires at least 2 characteristic symptoms: delusions, hallucinations, disorganized speech, grossly disorganized behavior, negative symptoms. For a significant portion of time during 1 month, Tom clearly meets this. At least 4 symptoms. Crucial criterion: continuous signs for at least 6 months, including a period of significant functional decline. Key point for Tom: unemployed a year due to erratic behavior. Neighbor reports progressive decline over months. Timeline supports schizophrenia over shorter-term disorders. Marked social and occupational dysfunction, losing his job, social isolation, self-neglect, fulfills another criterion. Presentation: prominent positive symptoms, hallucinations, delusions, and negative symptoms. Avolition, flat affect, is classic for schizophrenia. However, consider other possibilities. Schizophreniform disorder. Same symptom criteria as schizophrenia, but duration is shorter. 1 to 6 months. If total illness 6 months, including prodrome, then schizophreniform disorder would be the provisional diagnosis. Brief psychotic disorder, less likely, sudden onset, under 1 month, does not fit Tom's gradual decline. Schizoaffective disorder, no evidence of major depressive or manic episodes concurrent with psychosis. Most importantly, rule out medical or substance-induced psychosis. Although Tom reports no medical history or substance use, exclude these formally. Conditions that can mimic psychosis: autoimmune encephalitis, thyroid disorders, brain tumors, infections, substances that can cause psychosis, cannabis, amphetamines, withdrawal from alcohol. Diagnostic plan must include full physical examination, neurological assessment, and comprehensive laboratory tests, including complete blood count, metabolic panel, thyroid function tests, urine drug screen. If tests are negative, working diagnosis of schizophrenia is justified, guiding our subsequent management plan. Table of Contents. Part 4. Act 3, Pharmacology and Acute Management. About 5 section. Section 1, Choosing the Right Tool. An overview of antipsychotics. When treating a first episode of psychosis, as we see with Tom, the primary goal is to reduce symptoms and improve functioning as quickly and safely as possible. The cornerstone of this treatment is antipsychotic medication. These medications are essential for managing the acute phase and for preventing future relapses. There are many antipsychotics available, and they are broadly divided into 2 categories. First generation, or typical, antipsychotics. Second generation, or atypical, antipsychotics. Making the right choice for Tom involves a careful consideration of the benefits and potential risks of each option, tailored to his individual clinical presentation and needs. It is a decision that requires a strong foundation in pharmacology. First-generation antipsychotics, such as haloperidol, were the first to be developed. They are very effective at treating the positive symptoms of psychosis, like hallucinations and delusions. They work primarily by blocking dopamine D2 receptors in the brain, which helps to correct the dopamine overactivity in the mesolimbic pathway. However, their strong and non-selective dopamine blockade can lead to significant side effects, particularly movement disorders known as extrapyramidal symptoms, EPS. While still useful in certain situations, especially in emergencies, they are generally not considered the first-line choice for treating a first episode of psychosis due to this side effect profile, which can be distressing for patients and affect long-term adherence. This leads us to the second-generation antipsychotics, SGAs, which are now the standard of care for first-episode psychosis. This group includes medications like risperidone, olanzapine, quetiapine, aripiprazole. These are called atypical because their mechanism of action is more complex than simply blocking dopamine receptors. They tend to have a lower risk of causing the severe movement-related side effects associated with the older drugs. This improved tolerability is a major advantage, especially for someone like Tom, who is new to treatment. A positive initial experience with medication can be crucial for building a therapeutic alliance and encouraging him to continue with his treatment plan in the long term. The choice among the second-generation antipsychotics is a nuanced one. Each medication has its own unique profile of efficacy and side effects. For example, olanzapine and risperidone are often considered highly effective but come with a significant risk of metabolic side effects, such as weight gain, changes in blood sugar, and cholesterol. Quetiapine is more sedating, which can be useful if the patient has significant agitation or insomnia, but it also carries metabolic risks. Aripiprazole has a different mechanism of action and often a more favorable metabolic profile, but it can sometimes cause a feeling of inner restlessness known as akathisia. The best choice for Tom will depend on a careful discussion of these factors, balancing the need for symptom control with the goal of minimizing side effects. Section 2. Mechanisms and Side Effects. A balancing act. Understanding how these medications work is key to using them safely. As we know, first-generation antipsychotics like haloperidol are potent antagonists of the dopamine D2 receptor. This action is very effective at reducing positive symptoms but comes at a cost. The blockade of dopamine receptors in other brain pathways, particularly the nigrostriatal pathway which controls movement, can lead to extrapyramidal symptoms, or EPS. Acute dystonia, painful muscle spasms, Parkinsonism, tremor, rigidity, slow movement, tardive dyskinesia, involuntary, repetitive body movements that can be irreversible. This is why their use requires caution and careful monitoring for these debilitating side effects. Second-generation antipsychotics have a more sophisticated mechanism. They also block D2 receptors but bind more loosely and dissociate more quickly than the older drugs. This is thought to contribute to their lower risk of EPS. Crucially, they also act on other neurotransmitter systems, most notably serotonin. Most SGAs are potent blockers of the serotonin 5-HT2A receptor. This action is believed to help increase dopamine release in the prefrontal cortex, which may help alleviate some of the negative and cognitive symptoms of schizophrenia. This dual action on both dopamine and serotonin systems is what makes them atypical and often a better choice for patients like Tom. However, second-generation antipsychotics have their own set of significant side effects, primarily metabolic ones. The blockade of other receptors, such as histamine H1 and muscarinic M1 receptors, contributes to side effects like sedation and weight gain. Medications like olanzapine and quetiapine are particularly known for causing significant weight gain, dyslipidemia, abnormal cholesterol levels, and an increased risk of developing type 2 diabetes. This is a major concern as patients with schizophrenia already have a higher risk of cardiovascular disease. Therefore, choosing an SGA requires a trade-off: a lower risk of movement disorders in exchange for a higher risk of metabolic syndrome. This makes baseline and ongoing physical health monitoring absolutely essential. Aripiprazole stands out with a unique mechanism as a dopamine D2 partial agonist. Instead of completely blocking the receptor, it acts as a dopamine stabilizer. In brain areas with excess dopamine, like the mesolimbic pathway, it reduces dopamine's effect, thus controlling positive symptoms. In areas with a dopamine deficit, like the prefrontal cortex, it provides a low level of stimulation, which may help with negative and cognitive symptoms. This mechanism generally leads to a lower risk of both EPS and significant metabolic side effects. However, it is associated with a higher incidence of akathisia, an intensely uncomfortable feeling of inner restlessness that can be very distressing for patients and can be mistaken for agitation. Section 3. Starting the journey, dosing, titration, and monitoring. Initiating antipsychotic treatment requires a start low, go slow approach. This is especially important in a patient experiencing their first episode of psychosis. Individuals who have never taken these medications are often more sensitive to effects and side effects. Risperidone, a common starting dose might be 1 mg per day, titrating to 2 to 4 mg. Olanzapine, typical start 5 to 10 mg, target 10 to 20 mg. Aripiprazole, often started at 10 to 15 mg per day. The goal is to find the lowest effective dose that controls symptoms without undue side effects. The process of gradually increasing the dose is called titration. Step-up titration schedule. Titration lets the body adapt and lets clinicians detect emerging side effects early. Allows sufficient time at a given dose. It can take several weeks to see the full effect. During the initial phase, regularly monitor the patient's symptoms. Monitor the intensity of hallucinations. Monitor the conviction of delusions. Equally important, ask about subjective well-being. How is the medication making them feel? Are they overly sedated? Do they feel restless? That feedback is vital for fine-tuning the treatment plan. Given significant metabolic risks with many second-generation antipsychotics, monitoring is mandatory. Before starting Tom on olanzapine or risperidone, obtain baseline measurements. Weight, height, to calculate BMI, waist circumference, blood pressure, fasting blood glucose, a lipid panel, cholesterol, triglycerides. That baseline data is crucial for tracking changes once treatment begins. Monitoring must be ongoing, per clinical guidelines. Check weight frequently in the first few months. Recheck blood pressure at around 3 months. Recheck fasting glucose at around 3 months. Recheck lipids at around 3 months. Then reassess at least annually, or sooner if abnormalities are found. Proactively monitor for extrapyramidal symptoms with a physical exam. Check for tremor. Check for rigidity. Check for abnormal movements. Screen for akathisia. Ask about inner restlessness. Diligent monitoring is the cornerstone of safe pharmacological management. Treat the whole person, not just symptoms. Section 4. Calming the storm, managing acute agitation, flowchart, steps for managing acute agitation. When Tom first arrives at the emergency department, he is agitated, fearful, suspicious. Managing this acute behavioral disturbance is an immediate priority to ensure his safety and the safety of those around him. The first and most important step is always to attempt verbal de-escalation, approach in a calm, non-threatening manner, maintain a safe distance, speak in a clear, simple, reassuring voice. Acknowledge his fear and distress without validating delusions. For example, it sounds like you are feeling very frightened right now. This is more helpful than arguing about whether a secret organization is watching him. The goal is to build rapport and reduce anxiety. If de-escalation fails and Tom remains highly agitated, offer medication. Prefer oral medication over injections when possible. Use a rapidly dissolving tablet formulation. Olanzapine, risperidone. These dissolve on the tongue and absorb quickly, useful if a patient may cheek tablets. Benzodiazepines such as lorazepam can also be used, alone or in combination with an antipsychotic. Lorazepam gives rapid sedation and anxiety relief. If the patient is too agitated to take oral meds or refuses them and poses immediate risk, use intramuscular injection. This is called rapid tranquilization. Typical antipsychotics: haloperidol, olanzapine, aripiprazole, benzodiazepine, lorazepam. Example: haloperidol, 5 mg buzz, lorazepam 2 mg IM as a single injection. This combo calms the patient and reduces the risk of acute dystonia. In extreme cases with imminent severe danger not manageable by de-escalation or meds, physical restraints may be required as a last resort. Restraints carry significant physical and psychological risks. Use restraints for the shortest possible time. Monitor vital signs. Monitor physical comfort. Monitor psychological state. The goal of restraints is safety, not punishment. Remove restraints as soon as less restrictive management is possible. Document and review every instance of restraint use. Section 5. Beyond the basics, drug interactions and special considerations. Effective pharmacological management goes beyond choosing and dosing a single medication. We must consider drug-drug interactions. Tom is not on other medications right now, but that can change. Many antipsychotics are metabolized by the cytochrome P450 system in the liver. Cytochrome P450 enzyme system diagram. Other drugs can induce these enzymes, speeding metabolism and reducing effectiveness. Other drugs can inhibit these enzymes, slowing metabolism and increasing toxicity risk. Certain antibiotics can inhibit antipsychotic metabolism. Certain antidepressants can also inhibit metabolism. This can affect drugs like quetiapine and olanzapine. The result can be dangerously high blood levels. Another key consideration is medical comorbidity, cardiovascular disease, diabetes, respiratory illness. If Tom developed one of these, it would influence antipsychotic choice. For pre-existing diabetes or obesity, favor aripiprazole, favor lurasidone, favor ziprasidone. Be very cautious about using olanzapine. If he had a known cardiac condition, monitor his ECG carefully. Some antipsychotics can prolong the QTc interval. Management of specific side effects is critical. Acute dystonia, often caused by medications like haloperidol, treat immediately with an anticholinergic injection. Procyclidine, benztropine, Parkinsonian side effects, manage with oral anticholinergics. Akathisia, the inner feeling of restlessness, try dose reduction of the antipsychotic, or switch to a different agent, or add propranolol, or add a benzodiazepine. Remember, Tom is an individual. His response will be unique. Involve him in decision-making as his clinical state allows. After the acute phase, discuss options, benefits, and common side effects to empower him. Shared decision-making respects autonomy and builds the therapeutic alliance. Pharmacology is one tool within a comprehensive, person-centered plan addressing the whole person. Table of Contents, Part 5, Act 4, Plan of Care, Communication, and Discharge. Section 1, Crafting the Blueprint for Recovery, the Comprehensive Care Plan. Section 2, Building Bridges, Communication and Therapeutic Alliance. Section 3, Paving the Way Home, Structured Discharge Planning. Section 1, Crafting the Blueprint for Recovery, the Comprehensive Care Plan. Following the immediate management of Tom's acute psychosis, we must develop a comprehensive and holistic plan of care for his inpatient stay. This plan is not solely focused on medication. It is a multifaceted blueprint designed to address his psychological needs, social needs, occupational needs. The immediate priority upon admission to the psychiatric unit is to provide a safe environment, structured environment, low-stimulus environment. This therapeutic milieu is in itself a form of treatment, reducing the overwhelming sensory input that can exacerbate his symptoms. Regular observation by nursing staff will continue, not just for safety, but to build rapport and assess his evolving mental state, daily functioning, and response to initial treatment interventions. The care plan must integrate psychosocial interventions alongside pharmacology. Once Tom's acute symptoms begin to stabilize, he should be offered individual supportive therapy. This provides him with a safe space to talk about his experiences without judgment, helping him to make sense of what has happened. As his insight improves, a more structured approach like cognitive behavioral therapy for psychosis, or CBTP, can be introduced. CBTP can help Tom develop coping strategies for his persistent symptoms. For example, it can teach him techniques to challenge his delusional beliefs and reduce the distress caused by auditory hallucinations, empowering him to regain a sense of control over his experiences. Occupational therapy, OT, plays a vital role in addressing Tom's significant functional decline. An OT assessment will evaluate his ability to perform activities of daily living, ADLs such as personal hygiene, cooking, and managing his finances. The OT can then work with Tom in a graded manner to rebuild these skills and his confidence. This might start with simple, structured activities on the ward and progress to more complex tasks. Vocational rehabilitation is also a key component. The OT can explore Tom's past work experience, skills, and interests, helping him to set realistic goals for returning to employment or education in the future, which is crucial for his long-term recovery and sense of purpose. Finally, the care plan must actively involve social support systems. A social worker should be engaged early to assess Tom's housing situation, financial status, and social network. Given his isolation, reconnecting with family, if appropriate and desired, will be explored. The social worker can provide family education about schizophrenia, helping them to understand the illness and how they can best support Tom. They will also begin the process of linking him with community resources, such as housing support services and benefits agencies, to ensure that the practical foundations for his life outside the hospital are being built long before his discharge date arrives. Section 2. Building Bridges. Communication and Therapeutic Alliance. Communicating effectively with a patient like Tom who lacks insight into his illness presents a unique and profound challenge. The foundation of any therapeutic relationship is trust, yet his paranoia and delusions make him inherently distrustful. It is counterproductive to directly challenge his delusional beliefs, as this will likely entrench his position and damage any potential for rapport. Instead of arguing about reality, our communication should focus on the distress his experiences are causing him. Acknowledging his fear and suffering validates his emotional experience without validating the delusion itself. Phrases like, "That sounds incredibly frightening," "It must be exhausting to feel you are being watched all the time," can build an empathetic bridge. Establishing a therapeutic alliance is a gradual process that requires patience, consistency, unconditional positive regard. The clinical team must present a united, calm, predictable front. Every interaction, from offering medication to a simple conversation about the weather, is an opportunity to demonstrate reliability and trustworthiness. It is important to be honest and transparent in all communication. Explaining what you are doing and why, using simple and clear language, can help to reduce his suspicion. For instance, when administering medication, this is a medicine to help you feel calmer and less frightened, rather than, "This is to treat your psychosis." This frames the intervention in terms of his subjective distress. As Tom's symptoms begin to improve with treatment, his capacity for insight may slowly increase. This is a delicate phase that requires careful navigation. We can begin to gently introduce the idea of a medical explanation for his experiences. This is often best done by linking the treatment to symptom relief. For example, a clinician might say, "You've said that the voices aren't as loud since you started this new medication. Sometimes, when people are under a lot of stress, their brain can play tricks on them, and this medicine helps to quieten that down." This linking strategy helps the patient to form their own connection between the treatment and their improved well-being, fostering a medical understanding of their condition. Effective communication extends to the entire multidisciplinary team and must be documented clearly. A standardized tool like the SPAR framework should be used for handovers between shifts and for consultations with other specialists. This ensures that everyone involved in Tom's care has a consistent and up-to-date understanding of his presentation, his specific communication needs, and the strategies that have been found to be effective or ineffective. This consistency is crucial for Tom, as it reinforces the sense of a reliable and cohesive team working together to help him, which can be a powerful antidote to the chaos and fear generated by his illness. Discharge planning for a patient with a first episode of psychosis is a critical process. It must begin on the day of admission, not the day before they leave. The goal, a seamless transition from inpatient unit to community, reduce relapse and rehospitalization. First, establish a robust follow-up plan. Schedule a follow-up with an outpatient psychiatrist or with an early intervention in psychosis service within 7 days of discharge. Rapid follow-up reduces relapse and keeps care continuous. Include a detailed medication management strategy. Tom needs to know what medication he is taking, why he is taking it, the dose and the time of day. Give this in writing and with supports, for example, a blister pack, a dose set box. Detail physical health monitoring, when to see the GP for blood tests, and for weight checks. Create a crisis plan with Tom. List early warning signs, coping strategies, and clear contact information. Include the community mental health team and a 24-hour crisis line. Ensure a formal handover to the community team or the early intervention service. Do more than send a letter. Make a phone call or hold a discharge planning meeting. Involve the inpatient team, the community team, Tom and his family or neighbor. Use a structured SPAR handover, clinical information, risks, and the agreed care plan. Tell the community team about his social situation, OT progress, and the communication strategies that help him. That way, they can hit the ground running with proactive support from day one. Consider safety netting. Give Tom and his support network clear instructions on what to do if things go wrong. He and his neighbor should know what counts as an emergency and how to access urgent help. A safety net catches him if he starts to deteriorate. Send a comprehensive discharge summary to the GP outlining the diagnosis, the treatment provided, the follow-up plan, and required physical health monitoring. A well-executed discharge is not the end of treatment, but a managed transfer of care, paving the way for Tom's long-term recovery in the community. Our journey through Tom's case has provided a comprehensive roadmap for managing a first episode of psychosis. We began with an acute crisis and moved quickly from assessment to treatment, guided by the principles of safety, science, and structured communication. Safety, science, structured communication. The SPAR framework let us organize chaotic details into a clear clinical narrative, a methodical approach in a high-stakes environment. We identified Tom's symptoms across domains. Positive symptoms, negative symptoms, disorganized symptoms. These findings pointed strongly to a schizophrenia spectrum diagnosis. That initial assessment became the bedrock for everything that followed. Our rationale was rooted in pathophysiology, dopamine, glutamate, brain circuitry. That science connected his experiences to specific biological processes, so we treated an underlying brain illness, not just behavior. We recommended a second-generation antipsychotic, balancing urgent symptom control with minimizing side effects and promoting adherence. We focused on mechanism, side effect anticipation, and early physical health monitoring. Medication mechanism, side effect planning, physical health monitoring. Medication was only one part of a larger holistic plan. We integrated psychosocial interventions, supportive therapy, CBT, occupational therapy, to address functional decline and help him rebuild his life. Communication was central, especially with limited insight. We built therapeutic alliance with empathy and trust. Person-centered care fosters hope. Recovery is a marathon, not a sprint. Hospital treatment must link to discharge planning, early planning, structured planning, collaborative planning, rapid follow-up, clear crisis plan, warm handover. These steps create the scaffolding for long-term recovery. Final synthesis, from the emergency room to the community. Final summary slide, SPAR assessment, diagnosis, acute management, care planning, discharge. In a complex psychiatric presentation like Tom's, the first 24 to 72 hours are a critical window for intervention that sets the stage for the entire course of treatment. To ensure no vital steps are missed, here is a concise clinician's checklist of must-do items. First, prioritize safety. Conduct an immediate and thorough risk assessment for harm to self or others. Assess risk of self-neglect or accidental harm. Implement appropriate safety measures, such as one-to-one nursing observation. Use verbal de-escalation techniques to reduce agitation and create a calm therapeutic environment. These actions stabilize the immediate crisis. Second, initiate a comprehensive diagnostic workup. Rule out organic causes, even if psychosis seems primary. Perform a full physical and neurological examination. Obtain baseline blood tests, complete blood count. Electrolytes, liver function, kidney function, thyroid function. C-reactive protein. Perform a urine drug screen to exclude substance-induced psychosis. Secure investigations early to avoid missed medical causes and guide safe prescribing. Third, begin pharmacological treatment thoughtfully. Once medical causes are reasonably excluded and the patient is stable, do not delay antipsychotic initiation. Choose a second-generation antipsychotic based on symptoms and side effect profile. Start low and plan gradual titration. Record baseline metabolic parameters, weight, body mass index, waist circumference, blood pressure, fasting glucose, lipids. If agitation is severe, be ready to use oral or intramuscular rapid tranquilization per protocol, prioritizing the least restrictive option. Fourth, establish a holistic care plan, make an early multidisciplinary team referral, engage a social worker to assess social supports, assess finances, assess housing situation, involve an occupational therapist for functional and self-care assessment, begin building a therapeutic alliance with empathy, patience, and consistency, document all findings, decisions, and interactions clearly. These steps ensure comprehensive care from the outset, addressing symptoms and the social and functional impact of illness. In concluding our analysis of Tom's case, we can distill our approach into several key principles that represent the pillars of modern psychiatric care. The first and most important is early intervention. Early treatment of first-episode psychosis improves long-term prognosis. Delaying treatment risks entrenched illness and functional decline. Tom's case shows a vigilant community member initiating contact, and the health system must respond rapidly and effectively. The second principle is integrated, evidence-based treatment. Combine pharmacology with psychosocial interventions delivered in a coordinated way. Medication reduces symptoms so patients can engage in therapy. Therapy teaches skills and coping for long-term management and relapse prevention. Delivered by a multidisciplinary team, this treats the whole person, their brain biology, their psychological distress, and their social and occupational functioning. The third principle is commitment to physical health. People with severe mental illness face reduced life expectancy, often from preventable cardiovascular disease. Clinicians must proactively monitor and manage metabolic side effects. Physical health monitoring should be routine. Work collaboratively with general practitioners and empower patients to take an active role in their physical well-being. Finally, promote recovery and shared decision-making. Treatment aims for hope, purpose, and a meaningful life in the community. Recovery means people can live fulfilling lives despite mental illness. Shift from paternalism to partnership. Involve patients like Tom in decisions, respect their preferences and goals. This fosters autonomy, reduces stigma, and empowers recovery.